Good morning, good afternoon, good evening, everyone. Thank you for joining us for Neurology Morning Report this Tuesday. We are in, I think, the third of our series of three Neurology Morning Reports. We're going to take a break for a while because I'm going to be going on service and traveling and all kinds of things. So I'm glad we got to have these several in a row. And thanks very much to my colleague and friend Valeria for organizing our session today, in which I believe our colleague and friend Bayan is going to present a case, and our colleague and friend A is going to discuss the case, and Valeria will be doing scribing and teaching points, I believe. Okay, so Bayan and A, do you want to introduce yourselves briefly, and then we'll go ahead and get started?
Well, hi everyone. I'm A. I'm originally from Burma, but I'm now working as a research study at WashU, and Eric is also coming to grand rounds to WashU, so I'm so excited for that. And yeah, I'm also trying to apply for neurology residency, so I hope you all enjoy our discussion today.
Fantastic.
Uh,
Bayan, are you?
Hello, everyone. I'm Bayan. I'm a senior medical student from Syria, and I'll be presenting a case that I saw on my neurology elective recently. I hope you excuse me that my camera is not on, but my internet connection is currently not stable because of where I am.
No problem at all. Thanks for letting us know. We totally understand, and we are excited to hear and discuss your case together. So, Bayan, would you mind telling us just the chief concern that we'll be discussing today? And I
Yes.
should say also we have to, sorry, we have to end at 9 a.m. There's another CP solver. So if I'm deep down a rabbit hole, then and there are many more aliquots to go, don't give me any clues or give it away, but definitely feel free to encourage me that we have a lot more to discuss, and I will be glad to hear that. Valeria, we see something, but it's not the whiteboard. Okay,
Okay.
go ahead,
So
Bayan. Yeah.
just to pace ourselves, I'll have you know that we have a chief complaint, and after that we will be discussing four aliquots before we reveal the diagnosis. Okay. So our chief complaint is 4 days of progressively worsening headaches, culminating with a seizure episode.
Okay. 4 days of progressively worsening headache and then a seizure. What are you thinking so far?
Yes, for the headache and the seizure, I would be worried about the focal lesion in the brain that could be due to um, focal infection or inflammation or hemorrhage or a tumor, but it is like 4 days is kind of like set acute onset. So acute or subacute onset. So I will be more worried about the focal infection, inflammation. I can also think about like headache with underlying primary headache with another other underlying diseases causing seizures. So for primary headache, we have tension type and cluster migraine. And then it could also, for the secondary, we can think of like everything happening in the brain, like brain parenchyma itself, meninges, sinuses, ventricles, and also like in head and neck, it could be due to glaucoma for eyes, ears, nose, oral cavity, and also from systemic causes. It could be due to underlying hypertension or other systemic diseases like malignancy or HIV or syphilis. And I would also think of headache in its character, and so is that due to is it a new headache without any prior headache onset, prior headache episode, or is it a new headache with underlying diseases, or the headache just kind of its characters change during these episodes? So I will also be yeah, I'm just thinking all of these in my mind.
Fantastic. Well, thank you for telling us what you're thinking in your mind, and we can see in your mind is an encyclopedia of neurology knowledge, which was laid out very clearly and fantastically. I want to discuss a lot of the points that you said, which were the same teaching points I would make about this chief concern. But before I do that, let's just get a little more precise. You mentioned a lot of possibilities, right? Well, just go ahead and highlight what you said. That when we think of headache, we think of primary and secondary headache, or a primary headache are things like tension headache, migraine headache. People always then list cluster headache. They're equally common on step one, but actually cluster headache is very, very rare in real life, and that is under a larger umbrella of trigeminal autonomic cephalalgias, which have even rarer headaches. These are primary headache disorders, meaning just like the DSM-5, people get together and say, we've seen this pattern of symptoms and signs, and we're going to call it this, and these are the criteria, and this is what it seems to respond to as far as medication. And those are in the ICHD-3 online. It's like I call it the DSM for headache, or the taxonomy of flowering plants of headache disorders that just describes these things, and you can match your patient's headache there. Those are primary headaches. Secondary headaches, as A said, are headaches that are caused by some underlying process that we can identify. And those can include, as A said, and I frame it the same way, things in the head, things of the head, and then systemic conditions. So things in the head, as A said, what's in the head? There's brain, there's meninges, there's blood vessels, there's ventricles. Any of those being affected could cause a headache. And then of the head, A mentioned the eyes, the nose, the mouth, the sinuses, the ears, the jaw, and then in the neck, the arteries in the neck could have dissection. And then we all know from getting a bad flu or getting a vaccine, sometimes you have a headache, sort of just part of the inflammatory response. Okay, so primary versus secondary headaches, A laid out. So A, what do you think here, just given this chief concern? Is this going to turn out to be a primary or a secondary headache, and why?
Yeah, I will be more worried about the secondary headache because it also has associated seizure episode. So it could be due to any focal malignancy or any tumor, or like focal abscess or infection, inflammation, or hemorrhage.
Brilliant. Absolutely. So to distinguish between primary and secondary headaches on the history, we look for what are called red flags. And A mentioned that these have to do with the character of the headache, which includes how the symptoms the patient describes, the tempo of onset. It has to do with what makes it better or worse, lying down, sitting up, standing up, etc. We'll talk about those things if they become relevant. And it also involves the context. If we learn that this is a patient with a history of HIV or cancer or hypercoagulability or pregnancy, all different contextual factors that might make you worry about more dangerous causes of headache. Now, my experience, and I'm curious your experience, A, as someone who's practiced neurology in your country and is familiar with a lot of neurology. In my experience, when you ask about these red flags, did it ever wake you up at night? Did it come on suddenly? Most of the time, it still turns out to be a primary headache. It's rare that you see a, step one style patient presents with sudden onset, worst headache of their life, and it's a subarachnoid hemorrhage when it is headache alone and the patient's exam is entirely normal. You still have to work them up because they have identified a red flag. Their headaches have changed in pattern or character. It woke them up at night. But my experience in practice is that these red flags must be meant to be very sensitive, so you never miss something dangerous, but maybe not that specific. That doesn't change my practice. Someone says a red flag in the clinic, I say, this sounds like migraine. The patient's exam is normal. I bet this is migraine, but their migraines have changed in character or pattern. Their migraines have changed in severity. Something has woken them up at night. I always image them. If a patient, even in patients with cancer, with HIV, if the patient doesn't look sick, they're not having a seizure, the headache doesn't sound that concerning, and you say, I have to work this up. This patient has cancer, this patient has HIV, this patient is pregnant, all of which are risk factors for dangerous headaches. Usually, A, in your experience also, doesn't it just turn out to be a primary headache if the patient looks fine, has a normal exam, and it's just one red flag on the history. Is that your experience also?
Yeah, I also experienced lots of just primary headache in my clinics.
Yeah, perfect. So here there's a couple of red flags, right? We don't know if this is a new headache, but it's a headache worsening enough and quickly enough that that's very concerning. So one red flag, this is a relatively acute headache. It's a headache that's progressive. And as A said, it's accompanied by a seizure. So there's no localization mystery here today. We're not going to be doing the calculus of what's in the brainstem and where and this and that. This is a problem in the head, right? We know that. And probably in real life, this patient would be going directly to a CT scan without too much history and exam, though we would do it relatively quickly. So now, just to drill down even further, this patient has a new headache, or we don't know that yet. This patient has a headache evolving over 4 days and a seizure. You mentioned a number of possible things that could cause a worsening headache that's acute over a few days and a seizure. Just to highlight those again, what do you think are the most likely things, or what's coming to your mind with a headache that's progressive over 4 days and culminates in a seizure?
Mostly infections or inflammations.
Okay. Yeah, and what infections are you thinking of?
Infections like bacterial meningitis, viral meningitis, encephalitis. Yes, so with that acute onset or abscess.
Fantastic. I agree. Yeah. So this is an acute time course over a few days. So infectious inflammatory things tend to lead here with another couple of possibilities. And so, yeah, this could be a reasonable beginning of an illness script for meningitis, bacterial or viral, for encephalitis, for a focal abscess in the brain. I agree. There's one other thing I'm thinking of here. I'm trying to figure out how to get us there without just saying, guess what I'm thinking. But I'm thinking of another etiology where a patient would have a headache that worsens over a few days and then develops a seizure that is not an infection and that is not inflammatory. Just going through your thing, you thought about what could be in the brain, you thought about what could be in the meninges. There's some other compartments you mentioned in the head that could be affected and cause this presentation. Any come to mind?
Subdural hematoma.
Oh, thank you. Yeah, and A?
Yeah, like hemorrhage or
Yeah, what type of hemorrhage? Because usually, or what would be the cause of the hemorrhage? Usually an acute intracerebral hemorrhage just happens, right?
yeah.
I mean, just not sort of progressive like this.
Like hemorrhage in the ventricles or
Yeah, I'm asking you sort of a guess what I'm thinking question, which is maybe not asking the question very well. I think it's something probably you'll recognize when I tell you what I'm thinking here. So other things that could sort of follow this pace and then culminate in a seizure, I'm thinking of a venous sinus thrombosis, where the patient has progressive elevation intracerebral and intracranial pressure, and then ultimately has a seizure, either from some hemorrhage from the venous sinus thrombosis or just as the ICP rises, sometimes people can seize. Again, just thinking of your compartments, you talked about the brain, you talked about the meninges, you mentioned also for headache, we should think about the ventricles and the vascular structures. So thinking of something in the vascular structures that could behave like this. And then if the patient for some reason is developing acute hydrocephalus over several days, sometimes I've seen when the ICP gets high enough, the patient has a seizure, usually with alteration in level of consciousness at that point. You're just thinking of other compartments, but I agree with you. Meningitis, encephalitis, abscess, and then venous sinus thrombosis is something that came up just to my mind as well. Okay, great discussion. We talked about primary and secondary headaches. We talked a little bit less about the seizure, but since we have to end on time, we'll leave it at that for now and see what else comes out of the history. Okay, Bayan, what happened? What did you learn in the history?
Okay, wonderful discussion, and I'll focus on some of the questions that I saw in the chat and some of the questions that you brought up. So this is a 33-year-old male presenting to the ER for new onset headaches, progressively worsening since 4 days, and a new onset generalized tonic-clonic seizure. The seizure was witnessed by his roommate, who reported that it lasted about 2 minutes, but he is unsure. Prior to the onset of headaches, the only thing that the patient was able to report after he returned to his baseline after the seizure was that he was involved in a street fight, again, 4 days ago. He was punched in the face and he fell down during the fight and hit his head on the pavement. He reported feeling feverish after the fight, but he did not measure his temperature or seek any medical advice. His review of systems was negative, except for generalized back pain since falling during the fight. And he also reported some dizziness, blurring in his vision, and photophobia that have been progressively worsening since 2 days. He has also had severe nausea, leading to 3 vomiting episodes since the day prior to presentation. On his past medical history, he has occasional migraines. However, he states that the current pain and the current headache is not similar to his typical migraines that he has. For past surgical history, it is negative. For past medical history, for the medications he's on, he occasionally takes ibuprofen or acetaminophen for his migraines. He has no known allergies. His father has diabetes and hypertension. For his social history, he is unmarried and not sexually active. He works as a salesperson and he is an ex-convict. He was imprisoned for 1 year back in 2017, again for being involved in street fights. Regarding health-related behaviors, he denied smoking, drinking alcohol, or using any kind of illicit drugs. I can stop here or I can give you a bit of the exam.
You can stop here. Thank you, Bayan, for all that information. Okay. So what are you thinking now that you have this history and some more context?
Yeah, so seeing a lot of seizures associated with fever and other kind of meningeal irritation symptoms like blurring of vision, photophobias, I would be more worried about infection or inflammation in the brain.
Yeah. And
And
how would you, yeah, go ahead.
and yes, with increase also like with vomiting, there might also be some sort of like increased intracranial pressure.
Yeah, and how do you relate all that to the history of prior trauma?
Yeah, so it has a prior street flight. So it could be like he have trauma and then some sort of infections spread to the brain, or is it just a separate infection? I'm not so sure about that.
Yeah, great point, A. And I really like that you made that point, because if you read this story, you say, oh, first the patient had head trauma from this fight and then developed these symptoms. We could tell a story that the patient maybe developed a subdural hematoma, and that's venous bleeding and can be slower. And maybe it grew and grew to the point where he got a worsening headache and a seizure. Or as A said, sounds like this patient, unfortunately, due to their circumstances, is getting into fights with some frequency, and that could just be a red herring. And the patient got into a fight, nothing to do with it, and the patient got meningitis after that. Totally possible. Many patients who develop any illness will have some story of when it started. It started after my car accident. It started after I fell. It started after, you name it, some salient event. People want to find a story to try to make sense, and humans tend to see cause and effect. And we can fall into that same trap in medicine, right? The framing bias, where they say this is a patient who developed these symptoms after trauma as the one-liner, and you say, oh, well, it's hard not to draw a line between trauma and these symptoms. Now, they may very well be related here. They're very proximate. This is an otherwise healthy person. But as I said, it's possible this person happened to get in a fight that has nothing to do with the fact that they now have meningitis, and we wouldn't want our initial framing hypothesis of some type of trauma-induced problem to make us forget that if you took out the trauma and said, this is a young person with headache, seizure, fever, photophobia, nausea, vomiting, that sounds like a step 1 question for meningitis. But you could see how somebody might not think of that until too late if they're yoked to this seizure, to this prior trauma hypothesis. So a really brilliant point there, and very hard to maintain when we're not here in this context. When the patient is in front of us, we see the signs of trauma and we're thinking of trauma. So a post-traumatic subdural, post-traumatic venous sinus thrombosis, I think trauma can predispose to that. I'm not sure I understand why or how, but I'm pretty sure that's the case. Somebody can fact check me on that. Some unrelated process and the street fight is a red herring. Or depending on the severity of these patients' injuries, if there was a skull fracture and now there is the possibility of bacteria that colonize the sinus or nasopharynx finding their way into the intracranial compartment where they don't belong, maybe the patient has meningitis and it is related to this trauma. I saw a patient once who had a classic presentation for meningitis. We diagnosed meningitis, but she grew an organism that was not typical. I think it was group D strep. This is a long time ago. I only know neurology. I forgot all my internal medicine. Is there even a group D strep? Someone can tell me. It was some atypical strep, and I remember we thought, huh, that was weird. I was a resident. The attending said, I don't know why she had that. And we treated her, and she came back to the ED because her nose was running, and she had a cerebrospinal fluid leak. She had had a remote car accident, and she had a cerebrospinal fluid leak. And in retrospect, we realized, oops, that rare strep, we should have wondered, where did that come from? And it had come from the nasopharynx. So that would be a way to relate trauma and a subsequent meningitis. Maybe a little bit, well, I don't know, maybe a little bit fast for that to happen, but I'm actually not sure. Okay, in practice, this patient, while you're taking the history, would be headed to a CT scan because there's something acute going on in the brain. That would settle a lot of this. Either there's a subdural or there's not. And we'll go but for the purpose of our exercise, we'll go ahead and examine the patient. I just want to mention, we learned for step one, I'm in the habit of doing this. I do a lot of teaching with medical students where I say on the test and in real life, here's how it is. We learn this lucid interval thing for epidural hematoma, right? Where the patient has some type of head trauma and then they're fine, the lucid interval, and then they start losing their depressed level of consciousness. And that subdural does not behave that way. Anyway, in real life, I've seen patients with epidurals who are comatose from the beginning, and I've seen patients with subdurals develop the syndrome of chronic dementia, where slowly over time they accumulate so much chronic subdural. So anyway, on step one, if it's a lucid interval, it's an epidural, but in real life, that's not always the case. Okay, so again, this is a little bit of our exercise here, right? That in real life, this patient would go straight to CT, but we'd examine them as the gurney is going. I've found myself running after it and trying to check a few things. What A would you be curious to find on exam, look for on exam here with these hypotheses of venous sinus thrombosis, meningitis, subdural hematoma? What would you be looking for on exam?
Yeah, so first of all, I will look up about the trauma in the head. Is there any bruises or trauma on the head? And then I will start with mental status. Is he awake or is there any disorientation? Or with other focal signs, I will look about like increased intracranial pressure sign like bilateral pupillar edema, or is there any or is the pupil fixed or dilated, or other any focal signs like weakness, or is there plantars growing up? So I will also look all of these focal signs either.
Fantastic. Yes. So we want to know, are there any obvious signs of head trauma? Because we heard there was a fight. This patient really had signs of severe head trauma, or this was a fight and maybe the trauma could be irrelevant, as A mentioned earlier. And is there any focality to suggest a focal lesion, like a subdural, like a contusion from this trauma? And as you mentioned, pupillary asymmetry, a hemiparesis, maybe not full weakness on one side, or the patient might have had that in the chief concern, but maybe a pronator drift, maybe some slowed finger tapping on one side, though some of my residents really like to tell me there's a difference in finger tapping between the two sides, and I think it's often pretty subtle, and usually handedness affects how fast you can tap your fingers. If you really have a corticospinal tract lesion, it gets really slow and effortful on one side, but to tell me that this is different than this, I'm not sure. But these are subtle signs. If the reflexes are asymmetric, if there's a Babinski on one side, great points A. And then we're going to see what's going on the CT, but maybe we won't see anything. And so papilledema, if present on fundoscopy, would tell us the ICP is high, whether we notice it on CT or not. And I've definitely seen patients with meningitis who have a normal CT and have a very high opening pressure. Papilledema, to actually see it, it does take a few days to develop, so the absence of it doesn't exclude acute elevated intracranial pressure, but I agree, those would be the key things outside of a CT scan that would give us some clues to where we're headed here. Signs of head trauma, papilledema, focality, meaning asymmetric, motor exam, asymmetric pupils, or asymmetric reflex exam. Fantastic, I 100% agree. Okay, Bayan, you can tell us if in real life the patient got a head CT first before anyone examined them. We can do this like in real life. You can tell us if you examine them first or want to stick with the order you prepared the case in, that's totally fine also.
I think if I give you the head CT now, we'll have to wrap up in 5 minutes because it will reveal the diagnosis. So in the interest of developing our clinical reasoning, I will give you the exam first. So his temperature was 38.2, and that is 100.8 in Fahrenheit. His heart rate was 103, and his remaining vitals were normal. On general exam, he seemed like a well-groomed, middle-aged man. He seemed clearly in pain, and his eyes were closed at baseline. His head and neck exam revealed neck stiffness, and he had bite marks on the lateral aspects of his tongues. Cardiac and pulmonary exam were normal, except for the slight tachycardia. Abdominal exam was normal, except for some bruising, which seemed consistent with the history of fight. And for his CNS exam, his GCS was 14/15, that being E3, V5, M6. So his eyes were closed at baseline, but he would open them to verbal command. And he said that that was because the light exacerbated his headache. On mental status, he is conscious, alert, oriented. His pupils, there's no ptosis. His right pupil is 2 millimeters and reactive. The left one is 1 millimeter and sluggish. For cranial nerves, he has biocular diplopia on lateral gaze, and he also has weakness of eye abduction bilaterally. There is mild right facial deviation, and this was very subtle. There was a discussion about whether it was present or not, to be honest. And the remainder of the the cranial nerve exam was normal. Sensory exam was normal. Motor exam, he had weakness in his left upper and lower extremities, around 3/5, whereas the right was normal. His gait was wide-based, and the fundoscopy did show bilateral optic disc swelling. And again, I can stop at this point, or I can give you some basic labs.
That's okay. Let's there's a lot of great information there. Let's give Valeria time to write it and a time to synthesize it. If I heard for the neurologic exam, there's bilateral diplopia and abduction deficits. There was maybe right face deviation, but you weren't sure. And just to clarify, I know in different parts of the world, people say things differently, I've noticed, about facial weakness. Right facial deviation, you would be implying, Bayan, that the right face is stronger than the left face and the face was pulled towards the right, what we would call here, not that one is right or wrong, just different ways of saying it, what we would call left facial weakness. Is that right, Bayan?
Yes, yes, I think you're right.
Yeah. So yeah, when patients have facial weakness on one side and smile, it looks like the face is deviating. I found this confusing when I first started doing some work in other countries, and people would say right facial deviation and left-sided weakness. I'd think, are these crossed brainstem signs? Oh, they mean the face is deviating to the right because it's weak on the left. So different ways of saying different things in different parts of the world. Okay, so there is bilateral abduction deficits, maybe some subtle left facial weakness, some left-sided weakness, and papilledema and a wide base gait. Is that all the neurology here, Bayan?
Yes, the rest of his exam was either non-contributory or he was not cooperating enough to do it.
Excellent presentation of the exam. Thank you. Okay, A. What do you make of all this?
Yeah, so he has sign of like increased intracranial pressure, so bilateral pupillar edema, and also bilateral sixth nerve palsy. But he also have like left facial weakness and also weakness in the left side of the body. So it could be also focal lesion on the right side of the brain with increasing intracranial pressure affecting like sixth nerve and with bilateral pupillar edema. Yeah.
Yeah. Right. So those bilateral sixth nerve palsies you mentioned, you said this, but just to explain it to others who might not be familiar, as you said, that can be a sign just of elevated intracranial pressure without a focal lesion affecting the sixth nerve, right? Why is that? Do you know? How come you can get sixth nerve palsy from elevated intracranial pressure? Do you know why?
So it is kind of like the longest nerve like leaving from the brainstem. So it is probably mostly affected when there is some increased intracranial pressure.
Yeah, brilliant. Good for you. Yes, brilliant. So yeah, this is called a false localizing sign because it's focal, but it doesn't localize to a specific place. It's not like it's localizing to the sixth nerve nucleus or the sixth nerve fascicle. When the intracranial pressure is elevated, this can sort of put some tethering on the sixth nerve. I remember learning and saying this also, that it's the longest cranial nerve. Of course, the vagus is the longest cranial nerve, right? Because it goes from the brainstem to the lower abdomen. But within the skull, the sixth nerve goes over the clivus and through the cavernous sinus. It has this sort of long and tortuous course, and it's sensitive to elevated intracranial pressure. So that can be explained that way. So, and there's diplopia. So those are a package of intracranial pressure. What do you make, A, of the left-sided weakness and that left pupil being smaller and sluggish?
Mm. Mm. With the left pupil being small and sluggish, could also be uh, any cranial nerve 2 lesions there.
Would the pupil be small with a cranial nerve 3 lesion?
I'm not quite sure about that.
Yeah, I'm not quite sure about that either, to be honest. If we had a mass lesion with herniation, it would compress when it does do this, the third nerve, and usually you would get a larger pupil because the third nerve carries the parasympathetics, which constrict the pupil. So if they don't work, the pupil will be large. Classically, that's uncal herniation, where the temporal lobe pushes out against the anterior midbrain or the third nerve and causes ipsilateral dilated pupil. One of my mentors, Alan Roper, described that the pupil can actually enlarge on the other side, and did a lot of autopsies of patients who've herniated. There's old papers on this, I think, from the 80s and 90s, showing that something about how the brainstem torques during herniation, that you can actually get a contralateral dilated pupil or both pupils dilated, again, things that are not as simple as we initially learned them. So why would it be smaller? Well, why do you get a small pupil, A? What can cause the pupil to be too small? Lesion of what pathway?
It's affecting the sympathetic pathway.
Yeah. Yeah, the oculosympathetic pathway. So first, when we see anisocoria, unequal pupils, we have to decide, is the larger pupil the abnormal one or the smaller pupil the abnormal one? You don't always immediately know. If there's ptosis on one side, that helps. Ptosis and a large pupil is a third nerve palsy. Ptosis and a small pupil is Horner syndrome. Here, you're telling us that the left one's not really reacting very well, though at 1 millimeter, it would be pretty hard to see if it's reacting or not. So does the patient have a Horner's on that side? We didn't hear about ptosis. How would a patient have a Horner's who's young and healthy and had trauma could have a carotid dissection. The oculosympathetic, or those fibers of the oculosympathetic pathway go from the brain, from the hypothalamus, through the dorsolateral brainstem, down to the C8, T1 level, up over the lung apex, and then along the carotid through the cavernous sinus to the eye. So sometimes from carotid dissection, you can, from the swelling of the carotid, push on those fibers there and get that. I'm not sure either. And technically, the pupil should be reactive in Horner syndrome because 2 and 3 are working. It's just small because there's less sympathetic tone. But at 1 millimeter, it'd be really hard to say. So I don't know what to make of that either. The patient has some left-sided weakness. Sounds like there's probably a right-sided lesion, as you said. So we're about to get a CT scan. What do you think we're going to see on there? What do you think the CT scan is going to look like?
Yeah, it will show some focal lesion in the right side of the brain with some cerebral edema or increased intracranial pressure, compressing other parts of the brain.
And what type of lesion do you think it is?
Could be hemorrhage or other abscess or like infections or
Yeah.
inflammation.
Yeah. And then initially you thought this could be meningitis. Do you still think that's a possibility here, or?
No, I think it will be just more like focal lesions, hemorrhage, or other abscess.
Yeah, there is neck stiffness here, but there was trauma, so hard to know what to do with that. There's not really a fever. Close, but no, right? I'm not used to thinking in Celsius, but I don't think that's a fever. Someone can tell me. Yeah. So what could this be? There's focal weakness on one side, so there's probably a contralateral lesion of some sort. A cerebral hemorrhage evolving over 4 days, that seems a little hard to imagine. Maybe a subdural hematoma. Maybe the patient had traumatic subarachnoid hemorrhage. Sometimes that's just a little dot of blood in the sulcus. Sometimes it looks like aneurysmal hemorrhages, tons of blood in the cisterns, and the patients can sometimes look surprisingly well until they don't. I saw a case like that recently where the scan looked terrible. The patient looked actually very good. And then about a week in started to have vasospasm and ended up quite ill in the ICU. So this can happen. Yeah, for this patient to have a big enough hemorrhage to be herniating and causing elevated ICP, I wouldn't expect them to be conscious, alert, and oriented, right? So there's something here where the ICP is high, but the patient is conscious, alert, and oriented. Makes me think it's less likely that, one, less likely the patient has diffuse cerebral edema, or they would not be conscious. Makes it feel like it's less likely the patient has a hemorrhage so big or a mass so big that they're herniating and they're awake. So I maybe anchored myself on a hypothesis here of venous sinus thrombosis. And does the patient have a small hemorrhage causing the focality, but another process causing the elevated ICP, such as venous sinus thrombosis? But I admit I thought of that early, and I know my early thoughts, I have trouble pulling myself away from them. But that's one dissociation here, that there's a focal lesion and there are signs of elevated ICP, but the patient is conscious, alert, and oriented. So that makes me think there's probably not a huge mass here causing elevated ICP, that there's some type of focal lesion and elevated ICP from something else, but that's not diffusely affecting the brain parenchyma itself if the patient is following commands and all this stuff. So I'm going to guess on CT that there is some right-sided lesion, probably in the subcortical white matter, or that there's a subdural on that side. Yeah, maybe more a subdural. Why would the patient have a deep lesion? Yeah, unless it's an abscess, as you said. Yeah, I'm not sure. I think the patient's going to have something on the right side, but I don't think it's going to explain the ICP if the patient is awake. I think there's going to be some other explanation, and I still wonder about a venous sinus thrombosis. Would you see a venous sinus thrombosis on a non-contrast CTA? Could you see any clue that that could be the case?
with the non-contrast CT.
Yeah.
I think for venous sinus thrombosis, we have to use contrast.
Yeah. To see the venous sinus, you need to use contrast, and you need to tell the radiologist that that's what you're looking for, because you can get a CT venogram or an MR venogram, and the timing of when they acquire the CT or the MRI in relation to the contrast bolus depends whether you're looking at the arteries or veins. So you have to ask for that. If you didn't ask for it and the emergency room or whoever saw the patient first already got an MRI or a CT, if they got it with contrast, you can still see the sinuses on the post-contrast sequences, even if it's not dedicated venous imaging. So that can be a trick if you say, oh, I wish we had a venogram, but the patient already went to the scan. And then you look back and say, let me just look at the post-contrast sequences, see if the sinuses are filling. On a non-contrast CT, you can see clues, something called the cord sign, where there's hyperdensity over the area of the thrombosed vein because the thrombosis is hyperdense. And if the patient has a focal lesion from this, it's possible the patient had a small hemorrhage. Now, one of my mentors said, anytime you see an intracerebral hemorrhage or a stroke, just ask yourself, could this be venous rather than arterial in etiology? He said, of course, most of the time it's not, but if you don't ask yourself every time, you're going to miss it. But there are situations in which a venous sinus thrombosis is more likely related to some features of the hemorrhage. One is the location. Remember, you have a superior sagittal sinus that runs along the midline and then goes along the back of the head and then gives off two transverse sinuses, which come out laterally. So if you see a hemorrhage very close to the cortical surface, very close to the vertex, or bilateral hemorrhages close to the vertex, or a hemorrhage along the sort of transverse sinus, that location being very close to the cortical surface should make you think of a venous etiology. And if you see a small hemorrhage with a lot of edema around it, that can be another clue to venous sinus thrombosis or cortical vein thrombosis. Because if you keep your eye out for it, most primary intracerebral hemorrhages from hypertension or cerebral amyloid angiopathy, the hemorrhage has only a very small ring of edema around it. For some reason, the blood products don't cause much edema compared to an inflammatory or infectious lesion. However, if you think of the mechanism of venous sinus thrombosis, you have increased pressure, you're getting edema, and finally some small vein ruptures and you bleed into it. Often you have a small hemorrhage with a lot of edema around it. That could be a mass with hemorrhage into it. That could be an ischemic stroke with hemorrhagic conversion. But those are the situations in which I say, hold on a second. Could this be venous? Did we look for a venous cause? Okay, so I don't know if that's going to be the right answer, but I keep thinking about that based on this headache worsening and seizure, a little bit of focality, preserved level of consciousness, elevated ICP. Okay, Bayan. I guess we need to talk about labs. If there's anything remarkable, otherwise let's go straight to the CT since I know our time is limited.
All right. I'll have you know that his labs were completely normal except for a white blood cell count of 21K, neutrophils being 88%, so neutrophilic predominant. Apart from that, electrolytes, LFTs, coagulation panel, urine analysis, toxicology, serologies were all negative. There was sinus tachycardia on an ECG, but again, we already know that from his heart rate. We did get a chest X-ray because we were suspecting TB, meningitis, possibly because he has been in prison, and we know that this is a population that often gets TB. But the chest X-ray was normal. We also got a spine X-ray because he was complaining of back pain, and that was normal. And at this point, the patient had just gotten his CT, and his condition deteriorated. He became agitated. He seized again, and we felt like he was not stable enough for an MRI. So he was started on ceftriaxone, vancomycin, and Keppra empirically. And the CT head, without contrast, did show edema. And you are spot on because it showed hyperdensity over the area of the right transverse sinus. And we started the patient on heparin. Once he stabilized a bit, we did get an MRI which was by now day 3 of admission. So I will show you pictures of the MRI.
Great. Let me make you a co-host.
Yeah, and so again, this MRI was obtained on day 3 of admission, which is day 7 of his symptoms.
And you said there was edema, Bayan. Where was the edema?
I am not sure, to be honest.
No problem. Was it focal or diffuse? Do you know? And okay, if you don't
It
know.
was more diffuse, I believe, because the team decided not to get an LP.
More diffuse, yeah.
Okay.
Interesting deterioration. You can see this with elevated intracranial pressure that it's accumulating slowly, rising slowly, and then the patient hits a tipping point and really decompensates and seizes and has an altered level of consciousness.
Right. I hope you can see the MRI, and I do have 2 other pictures. Unfortunately, I don't have them as videos, just pictures.
No problem. Do you have the CT Bayan or no? That's okay if not.
No, I don't.
No problem. Just to show that cord sign, which is okay. A, what do you see here?
Yes, so there are hyperdensities along the occipital, along the like venous sinus.
Absolutely. So, oh, you can't see my arrow. Anyway, this is a cut. You see the eyes at the front, so we're pretty inferior in the brain. So we see the temporal lobes. You can see the pons, and then the cerebellum, and then yeah. If you're not familiar with reading MRI or CT, at least you see a very obvious asymmetry here, where there is hyperintensity on one side, and as A identified, that is the region of the right transverse sinus. Now, this looks to me like the gray matter is bright and the white matter is dark and the CSF is dark. So this is a flare image. So we're seeing a hyperintensity on flare here. Okay, this looks like something is going on in that right transverse sinus. So what's the next picture, Bayan?
Yeah, so this picture just showed us what we already suspected from the CT.
Yes.
I think the next 2 pictures will show something more. So this is one,
Hmm.
and
So
I'll
what
let you comment on it before I give you the official read.
yeah, what do you see here, A?
Yeah, I see like hyperdensity in the occipital region and also like in the near the brainstem, temporal lobe.
Yeah, do you know what structure that is? It's okay if not.
Kind of like basal ganglia.
Yeah, so along the superior going into the posterior part of the brain, that looks like the superior sagittal sinus is bright, hyper intense. And then that comes into a structure called the torcula, which is where the superior sagittal sinus and the 2 transverse sinuses come together right at the occiput. The torcula, I think, is, someone can tell me, Latin or Greek for wine press, I think. I don't know why that looked like a wine press to the early anatomists, but okay. And then at the midline going diagonally down, I think that's the straight sinus flowing into it. So this patient has extensive venous sinus thrombosis. Okay, Bayan, did you have another picture or?
Yes, I do, but that is not very that just shows the superior sagittal sinus of the thrombus extending.
Wow, so this patient has very extensive sinus.
Yes, yes.
And was there any hemorrhage or ischemia, Bayan?
Yes, so on the official read, there was vasogenic edema, there was thrombosis of the right transverse, sigmoid, and straight sinuses, with a right thalamic infarct.
Ah,
And unfortunately, I don't have a picture of this, but we also have opacification of the right mastoid ear cells.
hmm. Okay, so yeah, because this venous sinus thrombosis would not explain the unilateral weakness unless it has caused hemorrhage or infarction, but there was some deep infarction. Okay, how do you treat these patients with venous sinus thrombosis?
um, with anticoagulants.
Correct. This is thrombosis like anywhere else in the body in the venous system. You would treat it with anticoagulation. What if this patient had an intracerebral hemorrhage and venous sinus thrombosis? Is it still okay to give anticoagulation?
I think it will vary with some hospitals here, but I think some still give the anticoagulants.
That's right. Yeah, this is a rare instance where you can see blood in the brain on the scan and still anticoagulate the patient. There are studies, there are trials, they're pretty small. This is not a very common condition, that show that even patients that have intracerebral hemorrhage, when the cause of the hemorrhage is venous sinus thrombosis, they still benefit from anticoagulation because the cause of the hemorrhage is the venous outflow obstruction. And the only way to fix that is anticoagulation. And if these patients are identified early, they can do very well with anticoagulation. I've seen some cases where there's sort of an intracranial pressure crisis and they need hemicraniectomy to allow the brain to not herniate, and sometimes even catheter-based procedures to go chasing after the clot, because the heparin takes time to work. But yes, this is an interesting instance where even if you see blood in the brain, the indication is still to give anticoagulation. It's scary, but it would be scarier not to do that and have the entire venous system clotted off and not be doing anything there. Okay, Bayan, how did this patient do with the anticoagulation?
Yes, so with the anticoagulation, he was improving, but we felt that his rate of improvement was not sufficient, or what we would typically see with a patient who is started on heparin in such a case. And also, given his mastoiditis and his persistently elevated white blood cell count and fevers, we did consult ID and they recommended switching to linezolid and moxifloxacin, after which the patient did improve. And at this point, we still had cultures pending. They were still not growing anything. But after switching the antibiotic regimen, he did start improving. And as you said, this is very extensive cerebral venous thrombosis. We don't expect to see such extensive disease in someone who's very young, who doesn't have like a malignancy or some kind of other condition. So we did go down rabbit holes digging for some pre-existing conditions. So we did go back to the patient after he improved. We got an extensive history, trying to see if there's any history of autoimmune disease, malignancy, something that might explain his presentation. The only thing that he endorsed was a left testicular swelling, but he refused to be examined. And so we got a pan CT, which was unremarkable except for left indirect inguinal hernia. We got an echocardiogram, which was negative. We got an autoimmune panel, so ANA, anti-DS DNA, anti-cardiolipin, anti-beta-2 glycoprotein, and complements. And everything was negative. So our final diagnosis was extensive cerebral venous thrombosis, possibly due to mastoiditis. And the patient was discharged home on apixaban, and he's doing well.
Great. Well, wonderful care of this patient. Was there a thought, Bayan, that the patient also had meningitis from this mastoiditis, or just mastoiditis, post-traumatic mastoiditis leading to venous sinus thrombosis?
We didn't really see any signs of meningitis on the MRI, although we did initially suspect it, but the MRI didn't really show anything. And since we were getting it quite late into his presentation, and the antibiotics, which the first regimen he was on wasn't touching it, we felt like if he had meningitis, it would have showed up on the MRI. And since it didn't, we thought it's probably just post-mastoiditis cerebral venous thrombosis.
Yeah, brilliant reasoning through that. Yeah, meningitis doesn't always show up on the MRI. It can show up as meningeal enhancement. But yeah, this patient would not be safe to do a lumbar puncture on. And if there was fever and mastoiditis, as you said, you would treat as if the patient had meningitis while you're sorting this out. Then you found this mastoiditis, which, if that's the presumed source, then you, as you said, can work with infectious disease to find the right antibiotic regimen. Wow, fantastic case. Venous sinus thrombosis is not common, which means it can be missed or not thought of. And unless you know what you're looking for on the head CT, or you realize I'm looking for this diagnosis and a non-contrast head CT is not going to find it, this patient could keep getting sicker on antibiotics and people might not understand why. So good for you and your team for thinking of this and looking for it, finding it, and treating it. In our last few minutes here, any reflections on this case and our diagnostic journey here?
I think it's all. I I think it's all well explained by you, and such a interesting case to discuss. So just thank you so much.
Yeah, well, thank you. A brilliant discussion of thinking about primary and secondary causes of headache, recognizing this as a secondary cause being acute, wondering about infection, which was part of the answer, presuming there's some type of focal lesion. And then, yeah, for me, when that history of increasing headache over days culminating in seizure makes me think of some acute process here, like meningitis or encephalitis, but in the absence of fever. Again, remember the other parts that could be involved. A said meninges, we thought of meningitis. Brain, we thought of encephalitis. And then remember also the blood vessels and the ventricles. So could this be hydrocephalus developing quickly or venous sinus thrombosis developing quickly? And this is kind of the illness script of, again, not the only thing that could cause headache and seizure, but a few days of worsening headache, declining level of consciousness, and seizure is sort of the illness script for that condition, which is why I had thought of that. And great, just want to highlight the great point by A, that trauma was related here, but not in an obvious way, right? The patient didn't have a subdural, didn't have a contusion. It was related, but by a couple of steps to wonder if maybe the trauma had nothing to do with it, and we should be keeping our differential broad for causative secondary headache and seizure. That was a really important and pearl from A. And then the other thing is, you might say, well, headache and seizure, couldn't it be a tumor? Not over 4 days, right? A tumor wouldn't really worsen over 4 days, the headache from a tumor. So we're really in that kind of infectious, kind of the tail end of vascular things if it's happening over 4 days. So abscess, meningitis, encephalitis, venous sinus thrombosis, subdural. And it was the venous sinus thrombosis. Fantastic. Bayan, any last teaching points or things you wanted to highlight from this case before we close up?
I think I'll just highlight again the point that you mentioned, that this is a rare diagnosis, and if you're not looking for it, you might miss it. You might get a CT non-contrast and think, oh, it's clear, there's nothing, or there's just a bit of, intensity. It's not very specific or something like that. But this is the kind of diagnosis that if you don't keep in mind, you will not catch. So it's important to keep it in the back of your head, even if it's rare.
Absolutely. Yeah, as I said, one of my great mentors, Steve Fesky, who was at Brigham and Women's when I was a resident and early faculty and is now at Boston University, extraordinary neurologist and clinical thinker and researcher and teacher and administrator and kind of amazing everything. He was the one who taught me this pearl of when I was first a resident and saw one of these cases. And I said, how do you know when to think of this? I haven't seen one yet. And he said, you have to always ask if it's a hemorrhage or a stroke, could this be venous? And usually it's no, but if you don't ask every time, when your time comes to diagnose a venous sinus thrombosis, you could miss it. And that cord sign I mentioned, which you can Google and see a Google image, you don't always see that. You have to have really extensive clot like this patient has. To make it even more complicated, venous sinus thrombosis you can see pretty easily, as you could see on these sequences or on an MR venogram or a post-contrast study. But you can get cortical vein thrombosis, these tiny little veins over the surface of the cortex, which is a much harder diagnosis to make. These patients can present with headache and seizure, maybe a little bit of focal edema, one gyrus kind of swollen, people aren't sure, maybe a little bit of convexal subarachnoid hemorrhage, a little bit of hemorrhage into the sulcus that looks traumatic, but the patient didn't have trauma. Sometimes you even see a little, on susceptibility weighted imaging of MRI, the blood sensitive sequence, a little worm-like lesion. That's actually probably the thrombus in the cortical vein. And sometimes these need to be diagnosed with a digital subtraction angiogram, catheter angiogram. Okay, I'm seeing fly by in the chat that we don't have another VMR at 9. So I actually do have to still run at 9 to something else, but we can leave the meeting going and hear the teaching points from Amalpreet, who's been diligently scribing them. I will apologize that I have to sign off, but I want to thank Valeria for organizing, Bayan for bringing this very educational and interesting case for us, A, for a phenomenal discussion, and Valeria also for scribing, and Amalpreet for teaching points. And we will, with everyone's consent, absolutely podcast this wonderful learning experience we just had together. So sorry, I have to duck out. We'll have some more VMRs probably in a month or so. And thank you so much, everyone. Bye.
Perfect. What a case, Bayan. So maybe we can pass the mic to Amol so that she can share her teaching points. I've been eyeing them all the session, and I'm sure they're gonna be amazing.
Okay. So respecting everybody's time, I'll just rush through them. Thank you so much for the amazing case and the discussion. So if we talk about headache, I think we divided into primary and secondary headache, and the red flags we consider, we remember that by the mnemonic of SNOOP. That is systemic signs and symptoms, neurologic signs and symptoms, sudden onset headache, onset after 40 years, or change of headache pattern. So this patient had a neurologic symptom as well, that in the form of seizure, and the pattern of the headache changed, and the headache was acute. So we classified it as secondary headache. So we have two types of headaches: primary migraine tension cluster headache, and secondary headache, which is caused by an underlying process, either inside the head, outside the head, or in the systemic as a systemic disease. So we considered that our next step, which would reveal the diagnosis, would be CT head in this case, and we were suspecting infection or a venous sinus thrombosis causing an increased ICP. Then we also thought about some definitions like framing bias, when people make a decision based on the way the things are being presented, that we try to correlate the things with the things we see. For example, the symptoms are being correlated with the trauma. So the framing bias is also there, but if they're related, we can think of a skull fracture, and meningitis can also be caused by that. And then we have the elucid interval, which theoretically means a temporary period of time after head injury when the patient is symptom free. And we also discussed about the false localizing sign. That can lead to incorrect diagnosis and can occur in the context of raised ICP and spinal cord lesions. Like we were thinking in this case, that sixth nerve is affected. Then we also discussed about anisocoria, that is difference in the size of pupils. And when we have an isocoria, that is the pupil size is different, we need to decide which one of them is abnormal. If it's the small one that's abnormal or the large one. So if we see the small pupil plus ptosis, we think about Horner syndrome. That is due to sympathetic nervous system abnormality. Then if we have large pupil plus ptosis, we think of a third nerve palsy along with a deviated pupil. And then we also discussed about the cord sign, which is a CT scan finding. And we can see that in cerebral venous sinus thrombosis, that is hyperattenuating cord-like lesion in the brain. And ultimately, the patient was diagnosed to be having cerebral venous sinus thrombosis. So how do we treat thrombosis anywhere in the body? We treat it with anticoagulation. So in this case, also treatment of choice is anticoagulants. And if the patient, in general, if we say that the patient is having intracerebral hemorrhage, we don't give them anticoagulants because the patient is already bleeding inside the head. But what is that one condition in which we can give anticoagulants in an intracerebral hemorrhage patient? That's when the cause of intracerebral hemorrhage is the venous sinus thrombosis, because in that way we can stop that thrombosis by the anticoagulation, and the intracerebral hemorrhage can be controlled as well. So that was my main learning point today, that we can give anticoagulants in intracerebral hemorrhage plus venous sinus thrombosis. So I had lots of learning. I hope everybody enjoyed the VMR. Thank you so much for your time, and have a great day.